of health disparities is not new, but it is very front of mind presently, because there have been a series of headlines, a series of stories in the popular press as well as in the medical literature that begin to remind us of health disparities in general, and how, as is often quoted, when America catches a cold, Black America gets pneumonia. That is a way of perhaps a little colorful of describing the exaggerated impact of stressors like pandemic flu, or in this case, COVID-19, have a disproportionate impact on the Black community. So the issue of disparities is one that is actually, again, not unfamiliar to this group. In fact, if I were to put it to this group to think of sort of a summary statement of Black health, a summary statement of Black cardiovascular health even, I hazard to guess that most of you would pull up a very negative summary. The association of Black health or Black racial status with poor health, I think for a lot of us is automatic. That is, we think of early death, high rates of disease, and other deficits when we think of Black health. With that, let me go into a case, if you will, this being grand rounds. The case of, we'll call her Ms. A.F. She's an African-American woman who over her lifespan has had some significant exposures to environmental toxins, including growing up outside of Birmingham, Alabama, exposed to things like coal dust and other environmental pollutants that her father actually sold coal back in the earlier days of the century out from under his wooden porch. And so she was constantly exposed to that. She grew up at 17, began smoking, developed a 30-pack-year smoking history. In her mid-20s, married a steel worker who was heavily exposed to asbestos, who brought it home in his clothes that she dutifully washed. At age 42, she had a total abdominal hysterectomy and bilateral subpingural oophorectomy for questionable indications. Fibroids, I believe, was the reason, and this was done in the late 60s. She lived her life long devoted to the Southern way of eating, and in her latter years developed type 2 diabetes. All the while, we're talking about the middle decades of the 20th century in Birmingham and Bessemer, Alabama, which I think most of you probably know was an extraordinarily stressful time for African Americans, with essentially domestic terrorism. That is, bombings were occurring routinely of African American homes. We know the stories of other forms of violence against African Americans, both physical and psychological during that period. If I were to tell you that this woman, given this life of stress, strain, and exposure, had succumbed at age 55 with a myocardial infarction, I think none of you would be surprised. In fact, the woman I described passed away recently at age 91. Now, that's an anecdote, but I propose to you that it is not as unusual as you might imagine, that in fact, given all of the stressors that African Americans have been exposed to, that there's another side of African American health that needs to be considered. That is that indeed, many have succumbed to risk factors as described in the case. But an interesting and amazing group have survived extraordinary stresses. I think this begins to make the case, albeit at this point in the presentation anecdotal, it begins to make the case that African Americans, yes, indeed, do appear to have certain vulnerabilities, but that's only one side of a story that has clearly two sides. The second side is that African Americans have collectively shown resilience that is indeed remarkable, and it not only sets up if you will, a point of pride for African Americans, but I think for the purposes of our discussion, begins to introduce some interesting scientific questions that I think demand exploration. It looks like we're about to be able to share the slides. While we're doing that, let me give you the outline of the remarks that remain. The first point I want to emphasize for you all, and we've done it already, that American race-based health disparities, and specifically in cardiovascular disease, are real, pervasive, and refractory, and they seem to persist decade after decade, although things have improved somewhat. They are still large, and the disparities are a fact of our practice and a fact of our lives. The last 30 years have been an important era of establishing the severity and extent of these race-based health disparities. Cross-racial group comparisons, while they are useful to illustrate disparities, they may contribute to a monolithic and negative view of Black health. Black resilience is overlooked, and its study, I propose, may offer fresh insights, not only to Black health, but also the phenomenon of human resilience under stress. The Heckler report in 1985, which I think most of you are familiar with, stated very clearly for the American population and for the medical profession, the outlines of disparities as they exist between Black and minority patients and the majority. There's a cover, well, you don't see this yet, do you? Let's see. What I see is the outline displayed in the tile. Is that what everyone else sees, the outline?
It should be. So if you just let me know when you want me to advance the slides, I should be able to do it for you.
Okay, let's advance the slides. Okay, the Heckler report, again, issued by the Secretary of Health and Human Services in 1985, was a landmark document that outlined the Black and minority health disparities when compared to the white majority population. If you'll continue to advance, let's see, and now I can't really see the smaller slide. I'll go, dear. Okay, well, I'll try to make it out. It's very, very tiny, but let's go with it. Some of the quotes from the cover letter for that report are remarkable in that Dr. Heckler talks about the fact that these disparities have been noted for years prior to the report. Next slide, and the next slide. Okay, and that these dramatic, I'm sorry, go back one. These dramatic differences were an affront, if I recall the quote correctly, an affront to the ongoing genius of American medicine. And again, this made the point for us clearly that we all had work to do to resolve these disparities, which some have estimated cost America in economic terms nearly $1 trillion over the span of, I believe it was a 10-year estimate. So this has not only real human tolls with excess deaths among the African Americans numbering close to 80,000 per year, with a third of those being tied to cardiovascular disease, but also there's a huge economic cost. So there's a dual incentive for us to do something about this. Next slide. The concern about health disparities led to many responses, and one particularly bold response was the Jackson Heart Study, which I had the pleasure of leading as the inaugural PI and director. And there we explored in great detail in a comprehensive way, and continue to explore in Framingham Heart Study style, those things that contribute to disparities between African Americans and others. But the Jackson Heart Study distinguishes itself by focusing within the Black population. And such focus, I think, contributes to an appreciation of the heterogeneity of African Americans. Being Black and the health consequences of that in the United States is not one thing. It does not produce one set of circumstances, one set of outcomes. African Americans exposed to many stressors, environmental and behavioral, as well as those things totally beyond their control, have a wide range of outcomes. And I think often, particularly when we're doing regression analysis, Black winds up being a single variable as though it is one thing, and it clearly is not. Next slide. The Jackson Heart Study was launched in the midst of gross disparities, which you can see illustrated in this graph, which basically compares the national trend for white males over a series of decades, where you can see a widening gap between Black men in Mississippi against the national landscape for white men. And one thing I would ask you to note is that if you look at the beginning of the curve for African American cardiovascular mortality among men, and the end of that curve, while there's wiggling around over the decades, things seem to jump up and down. In the end, the estimate per 100,000 for African American health was largely unchanged over the course of a 30-year span. That is, 30 years passed, and at the beginning and the end, the death rates were about the same. That represents a full generation. Next slide. So disparities then are real and pervasive, as we've said, but I have to say to that, of course there are disparities. And it was put simply and eloquently by W.B. Du Bois at the beginning of the 20th century, when he, in his treatise, The Philadelphia Negro, said, one thing we must, of course, expect to find is that there's a much higher death rate at present among Negroes than whites. They have in the past lived under vastly different conditions, and that is still true. And I think, again, most of you know who W.B. Du Bois was. He's the first Black American to receive a PhD at Harvard in sociology, and went on to become iconic in his writings and speeches. What he said then at the turn of the century has been echoed in countless papers in the medical literature since, which with numbing regularity report the deficits in African American health. You've all read the papers. Independent of traditional risk factors, African American individuals have markedly increased risk in pick the variable, pick the outcome. And it's generally stated in terms of Blacks compared to whites are worse off. In fact, at one point in our history, and writing around the same time, a noted and very widely respected statistician, one of the first people to point out the connection between smoking and lung and throat cancer, was so impressed at the rate and the direction of differences between Blacks and whites that he predicted the gradual extinction of African Americans. A dramatic prognostication, but one that was also echoed in the halls of Congress around that time. As we know, that did not turn out to be true. I guess there's evidence of me speaking to you today. Um, and in fact, some interesting signals have emerged since those observations at the beginning of the century that I think, again, get back to the point that I opened with surrounding the issue of resilience. Many of you may remember the Evans County Heart Study. This was actually done primarily in the mid to late 60s. And here, observers looking at the health of a biracial community in southeast Georgia noted that, in fact, instead of seeing excess coronary deaths among African Americans, that coronary heart disease prevalence and incidence for African Americans were actually four times lower than the rates for Southern whites in the same community. And this was found principally by the work of Dr. Charles Hames, but it's been continued by others. And the interesting thing about Dr. Hames was that he was the only primary care physician in the county. So everybody was his patient. And his observation was that African Americans were not having heart attacks, even though they had higher rates of smoking and hypertension in the community. And he went about trying to figure out what was going on. A lot of interpretations, a lot of data was pulled from this community. And ultimately, one of the large conclusions was that the fact that the community was so radically socially stratified, that is, most of the whites were landowners, shopkeepers, most of the blacks were sharecroppers, and that the vigorous life of the sharecropping African Americans somewhat negated the impact of some of their risk factors. And in fact, higher HDLs were found among African Americans in that community. But it is an interesting signal of resilience in a stressful and risk-laden environment. There are other interesting signals. So signals of African American health despite adversity and risk. The Jackson Heart Study we talked about a little bit already. And indeed, Jackson Heart reveals that hypertension, which we all know has tremendous correlations with diet and stress. Jackson Heart Studies documented discrimination, perception, and other neighborhood effects, and other things that put African Americans in a category of being at higher risk than the general population for the development of hypertension. And let's see, if you go back in the slide, I wanted to do the reveal a little bit. Yes, no. Back to the health in the face of high risk slide. One, boom, boom. Yes. So many risk factors for the development of hypertension exist in the Black population. And next slide, the Jackson Heart Study indeed corroborates this. And the Jackson Heart Study, briefly, is a study, I mentioned that it's Framingham style, but it enrolled about 5,300 African Americans in the Jackson, Mississippi area and follows them longitudinally. Amazingly, by age 60, 80% or greater than 80% of the African American males in the study have hypertension. That is an unfortunate and not for many surprising fact. And that's where we focus. And, you know, and that makes a lot of sense that we focus on this high risk group and this poor outcome, if you will. Rarely do we think about the 20% who somehow live through all of the stresses, strains, exposures that Southern African American men have and don't develop hypertension. I think that's at least as compelling a circumstance for research and understanding as the high risk situation. Next slide. The in the African American study of kidney disease, it was this was a leading study, or is a leading study, that documented the impact, the importance of the APOL1 risk allele in predicting the development of kidney failure. While it was this risk allele was seen to be determinant of CKD. In fact, 40% of the patients in the high-risk group with that particular genomic profile did not progress to the composite renal outcome. What accounts for this sort of divergence from your genomic burden to your outcome? You might encapsulate that phenomenon in the notion of resilience that may be related to what's going on in other parts of the genome or epigenetic phenomena. Next slide. In the Dallas Heart Study, we all know the PCSK9 story. Well, an observation among less than 200 African Americans in the Dallas Heart Study led in many ways quite directly to the development of the blockbuster drugs that we use in controlling difficult to control LDLs. These African Americans were outliers that were really hiding in plain sight. That is, African Americans who had an unusually positive cardiovascular outcomes. And it led to the discovery of a genomic profile that actually undergirded the observation of a resilient group of African Americans. And the disparity crossover among the elderly is an interesting phenomenon that's been noted for years. And the slide, not as clearly as I had hoped, but the slide is intended to show you that at least since 1973, and clearly going back before then, African American women who are depicted in the solid black line, who lived to be in their mid to late 80s. If the African Americans, African Americans in America lived to the mid 80s, they in fact had at least as long a life ahead of them as their white counterparts. In other words, the observation that African Americans had excess deaths for every, excuse me, for any given age was turned on its head once African Americans made it into the elderly range. The basis of this crossover, there's been much speculation about it, but again, it's another signal that all is not negative when it comes to African American health. And again, I think that part of the story, both clinically and in research, needs to be understood and appreciated for a multitude of reasons. Understanding the phenomenon of the maintenance of health in the face of risk, I think, is an important line of American research that is underdeveloped and could hold important keys to how we should approach the resolution of health disparities and how we improve outcomes among African Americans. As James Baldwin said in reviewing circumstances in Harlem in the mid-60s, he says the wonder is not how many African Americans succumb to the circumstances, but the wonder is that so many survive. Next slide. So we're over halfway through the talk, and I'm presenting some opening questions. That is not, don't be discouraged. The talk won't go on for another 37 minutes. And I appreciate everyone bearing with the technical difficulties. But the opening questions include, Next slide. What are some of the contextual and environmental factors that might be tied to resilience among Blacks? They may fall in several categories: subjective, objective. Um, Questions like, are there these environments of unexpectedly good health? Do the residents of these, let's call them mini blue zones. I think a lot of you are familiar with the concept of blue zones, those areas on Earth where people live to advanced ages. Um, and I know the subject of National Geographic investigations and a lot of curiosity worldwide. Are there areas where people are doing particularly well? And is it on the basis of different risk profiles? Are they uniquely resilient? Other questions, what individual characteristics might help explain any observed resilience? Is this a psychological construct? Is there a biology underneath it? And are there genetic and epigenetic underpinnings? And are these objective markers, are there objective markers of individual physiologic resilience? And is this something that can be acquired? What I'll talk about today will be the early results of a study that we call MECA. And the early results will focus on the psychological and psychosocial aspects of these questions. So MECA is the Morehouse and Emory collaboration on cardiovascular health equity. This is a diagram of how the project is organized. What you should take from this is that it is a multi-level approach to understanding people who have unexpectedly good cardiovascular health, despite other factors that would predict more difficulties in cardiovascular health. So we look at the context, when we call that the population project, where we try to identify environments that either are producing low or high cardiovascular health indices. The clinical project will actually bring in people from a variety of environments across the Atlanta metropolitan area. And the basic project will look at epigenetic and metabolomic aspects of this issue. Next slide. For those of you who are unfamiliar with Atlanta, it's an ideal laboratory for looking at heterogeneity in African Americans because of the heterogeneity of the African American community. It is a huge community, numbering nearly 2 million African Americans, second only to the New York-wide metropolitan area in the number of African Americans. And there's a wide socioeconomic status range from the Tyler Perrys of the world to who are feel just extraordinarily, extravagantly rich, to individuals who are living on the streets who are African Americans, and everyone in between. Many of the studies on African Americans were actually not based in this very obvious site for the study of African American heterogeneity and health. The first project, this is the population project, actually has co-PIs, one of whom spent some time in the Yale orbit and is now a professor at Emory. And she's paired with Dr. Peter Baltras of Morehouse School of Medicine. And they're looking at the population and looking at the context that might be supportive of a resilient African American profile. Okay, so the purposes of that project to understand contextual and individual factors that contribute to resilience. The first aim was to identify resilient and at-risk communities, census tracts, neighborhoods across the Atlanta metro. The second aim was to look at contributory factors. You know, what can possibly in an environment, what can account for these observed differences? And three, to examine the relationship between resilience factors and an index of cardiovascular health, and we chose the Life Simple 7 score. This gives you a picture of what's considered the Atlanta metropolitan area up there in the northwest corner of the state. We've talked about the size of the population, its heterogeneity. And at first pass, when we wanted to see if there were neighborhoods across the Atlanta metropolitan area that showed differences in cardiovascular health among its Black population, the first analysis was easy and showed us something very predictable. And that is that money matters. And if you look at the top 10% of cardiovascular outcomes in terms of negative cardiovascular outcomes, and the neighborhoods that would fall in the bottom 10% of statistics, what you found was a profound difference in income. As you can see, the 65,000 to 27,000. Now, the analysis could have ended there, and we had one more set of papers pointing out the fact that socioeconomic status is one of the biggest risk factors when it comes to cardiovascular outcome. But that is not what we were looking for. We were looking to look beyond socioeconomic status to see if there were other indicators if you control for socioeconomic status, that still distinguished communities along this axis of good, resilient environments versus environments that were associated with poorer outcomes. And our statisticians came up with a method to do just that. And we were able to identify 220 communities that sat at opposite poles of cardiovascular health for African Americans, but that had almost identical median incomes. In other words, we took income off the table for a moment to look at what other factors might be at play and might be independent of income. And you see here the profile of those communities in terms of cardiovascular outcomes. You see the similarity in the median income, 46,000 to 45,000, but vastly different mortality rates, and that's cardiovascular mortality. Vastly different ED visit rates for cardiovascular disease, and admission rates for cardiovascular diagnoses were similarly widely disparate. So in answer to the first aim, are there factors or are there areas where if you control for the income, the proxy for socioeconomic status of these communities, can you find areas where there is unexpectedly good, there are unexpectedly good outcomes for cardiovascular health, and those that are at the opposite extreme? And the answer is yes, and it's depicted in blue and red, with the red being the hot spots, and blue being areas that have lower than expected cardiovascular negative cardiovascular outcomes. So blue is good, red is bad, and often you see that the neighborhoods are physically contiguous one with the other. So having established that, we want to take a look at what might be contributing to this. And this analysis that I'll give you here looks at cardiovascular health as the outcome of interest. So what factors did we hypothesize might be involved in all of this? So some of the contextual factors include things that you might expect, things that reflect neighborhood health. And they're listed on the next slide. Aesthetic quality, walking environment, much has been made of neighborhood walkability, safety, violence, and the perception of violence in the neighborhood. And then things that speak to what is referred to collectively as social capital, activities with neighbors, social cohesion, and of course, the issue of accessibility of good food. Next slide. The next slide lists some of the questions, examples of some of the questions from each of the scales. And to summarize the outcomes for this analysis, what we see is that evidence of community social cohesion and evidence of activities with neighbors were the most profoundly influential characteristics in the neighborhood environment that was correlated with positive outcomes, an outcome being ideal cardiovascular health. You see the p-values. The next slide emphasizes those p-values for social cohesion and activity with neighbors. An interesting finding. If we look at what was driving the positive correlation between those variables and the Life Simple 7 score. Next slide. And the next slide. We see that, no, go back to the red, yes. We see that positive scores for exercise, diet, and BMI dominated that relationship. So, so to state it again, social cohesion and activity with neighbors were important, and that importance was expressed through higher levels of exercise, diet, and lower BMI. Activity with neighbors also showed a very similar driving force behind the positive Life Simple 7 scores. That is, positive measures of exercise, of diet, and BMI were the key contributors to the positive outcomes. So, in summary, desirable neighborhood characteristics were linked to the greater occurrence of ideal cardiovascular health among African Americans. Desirable neighborhood characteristics also distinguished resilient census tracts from, I'm sorry, I'm having another technical difficulty, but I think you see displayed in front of you that these characteristics in this clinical subsample showed that there was a resilient profile related to the occurrence of social cohesion and activity with neighbors. Those communities that scored high in those indices were healthier communities. So the social environment is particularly important. And again, social cohesion activity with neighbors, clearly important. And these observations suggest areas that we might begin to focus in neighborhoods that might actually improve cardiovascular health for the larger group. Earlier work in the Jackson Heart Study predicted this, and we found that derangements of glucose metabolism and abdominal adiposity measured by CT scan in the Jackson Heart Study correlated with neighborhood deprivation and perceived lack of safety. Those characteristics of the neighborhood were indeed impactful in some of the cardiovascular risks that the African Americans faced. Psychosocial factors were also key. This shows some of the questionnaires that we use and some sample questions: environmental mastery, purpose in life, optimism, and low depressive symptoms. And each of these were found to relate to the occurrence of lower than expected cardiovascular, negative cardiovascular outcomes. In other words, positive health associated with these positive affective measures. Another part of the project that we called MECA involves an in-person clinical assessment of all of the factors you see listed, the classical risk factors, measures of oxidative stress, inflammation, and regenerative capacity, and measures of subclinical vascular disease. And looking at some of these classic measures, including pulsatile arterial tonometry on the next slide, as well as carotid IMT. All of these were looked at in relation to the observation of individuals coming from neighborhoods that had impressively good cardiovascular health, despite what we would expect by the socioeconomic status of the neighborhood. And again, in looking at an objective measure like peripheral arterial tonometry, we found that, interestingly, activity with neighbors and social cohesion were related to positive measures in both arterial stiffness, measured by pulse wave velocity, and by augmentation index. And that's indicated on the following slides. Very good. So move to the next slide, which summarizes these findings that are pending publication. So vascular function in neighborhood and neighborhood are related, and those measures, again, of social cohesion and activity with neighbors have an objective correlation that ties to subclinical disease. These things are good, and they predict good cardiovascular health outcomes. The basic project, time will not allow for us to go into this very interesting aspect of what we're looking at. But we're looking at microRNA profiles and metabolomics of individuals that show unexpectedly good cardiovascular outcomes, despite, again, some of the classical stressors tied to African-American life. And we expect that these findings, as they emerge, will open up some new avenues of investigation. Some of the preliminary findings indicate that there are distinct microRNA and metabolomic profiles for African-Americans with low versus high cardiovascular health, that metabolites are differentially expressed and tied to the differences we're observing in vascular function. And neighborhoods are important in all of this, in the neighborhood environments, as described in prior slides. And identifying a connectivity between microRNA and metabolomic networks will enable the development of robust biomarkers and may provide new insights. So I hope through some of the technical challenges here, I've been able to communicate a few points for you to consider. Cardiovascular health disparities, again, negatively impact African-American health. And these are real, and there's much work yet to be done. And I think the recent epidemic is showing us in clear terms that there's much to be done. And while Blacks as a group have worse CV health statistics, there is substantial intraracial heterogeneity pointing to the phenomenon of resilience among African Americans. This is not to suggest that resilience is something that African Americans have exclusively, but I think African Americans have lived under circumstances that have required this resilience. Indeed, contrary to some of the predictions in the earlier part of the 20th century of the demise of an entire people, African Americans very often are vigorous, long-lived, and have weathered tremendous adversity to live long and healthy lives. And acknowledging this and appreciating this sets up important opportunities, not only for completing this narrative of African American health, but also it sets up important questions that I think may have not only psychological but biological underpinnings that we need not ignore, and that may point to fresh approaches to resolution of health disparities. You know, the life of African Americans across the century just concluded, as well as the first 20 years of this century, can be characterized as difficult when we take the collective as and look at the actual lived experience of many African Americans. The image you see in front of you of the rose coming through the concrete, I take from a song, The Rose in Spanish Harlem, and one of the um, sort of the lyrical highlights of that song talks about how this young African American is growing up beautiful and strong despite the rigors of the city. And the singer says, she's growing in the street right up through the concrete. Life for African Americans in too many instances can be as hard as concrete. However, so many African Americans are living long and healthy lives. Despite the distressing headlines, the constant drumbeat of African American deficit and shortened lives and a high risk, there is another story that is staring us in the face, that is hiding in plain sight, that may offer new approaches to the resolution of health disparities. But I end with this important note. Promoting resilience without also working to address the societal conditions that often make resilience necessary is only a partial response. The vast majority of the everyday challenges that affect many, but not all, African American families, such as institutional racism, poverty, and others, are issues of social justice. The onus can't be merely on the families to adapt to threatening conditions. The conditions must be altered. As cardiologists, we are leaders. We're leaders of our profession. We're leaders in the community. We have access. We have education and knowledge. We have influence. And as a final note, tagged on to a discussion of science and epidemiology, I would offer that we have a real responsibility that I hope as leaders of medicine will embrace, to keep the emphasis on us getting to the underpinnings of these disparities and using our influence in whatever sphere to work towards their elimination. Thank you very much, and I'm afraid I didn't leave much time for questions, but I'll stop my remarks here. Thank you.
Dr. Taylor, I don't know if you can hear me. It's Eric Velasquez.
Hi.
Hi. First of all, thank you so much on behalf of Yale for presenting to us under these technical challenges and remotely. And we hope to have you here in person in the future. My question addressed this issue of resilience, and I kind of put here in the chat that, you've spoken a fair bit about resilience perhaps as a modifiable risk factor. Can you speak to, there's been a fair bit around social justice training and other mechanisms, and I guess the question is, do you envision challenges with regards to randomizing individuals or groups to different types of resilience training, particularly in the African American community, to further evaluate kind of their efficacy? And what are the ethical implications of that kind of strategy of investigation?
Yeah, I appreciate the spirit of the question. I think it is indeed a challenging notion to undertake resilience training. We are experimenting with that in some small, very specific groups. To resilience training can be adapted to a variety of targeted outcomes. So for instance, we're looking at something called the GRIT intervention for former NFL players who are suffering from a variety of ailments, including chronic pain. We are just beginning to look at how that might modify pain and blood pressure in this group. Dr. Marty Seligman out of University of Pennsylvania has resilience training that he employs with the armed forces with positive effect. And it is his, I think, dream to take his model of resilience training into communities to see if he can impact outcomes in a variety of ways. I think other ways of taking principles of resilience training and weaving them into standard approaches exist. One example that comes to mind is in type 2 diabetes, there are some long established evidence-based approaches to self-management for diabetics that have produced important improvements in outcomes and things like cholesterol, blood sugar control, and blood pressure control. In a recent study, investigators in Texas took some of the elements of resilience training and modified their approach, modified the standard self-management training, and found that they could actually impact hard measures of cardiovascular risk factors in a positive way by introducing elements of resilience training. I think that there's potential. I think is a sort of a raw and relatively new and psychologically based science. I think that it's important to continue to work with models and interventions that are like those. But I think also we have to understand the complexity of this notion of resilience. Clearly, there are psychological aspects to it, but it is not solely a psychological construct. And I won't go into that too deeply, except to say it's obvious if you have a dish of cells and you put in a toxin that kills half the cells, well, all the cells were exposed to the toxin, but half survived. There's no cognitive input to the surviving cells. There's no behavioral aspect. It just is on a very in a very biological way. I think as the concept of resilience gets explored in more depth and our approaches get tested in more context, I think we'll evolve further in being able, one, to assess what is resilience and in what domains, be they physical or medical, be they cardiovascular, neurological, immunologic, that we'll be better able to get a handle on some of these things and come up with more precision in how we approach this notion of acquired resilience. That was somewhat long-winded, and I hope I answered the question, or at least got close.
You did, thank you.
Dr. Taylor,
Yes.
this is Jeff Bender here. I wanted to also thank you for joining us. That, by the way, that's a real thank you, not a virtual thank you. And I did want to ask you, clearly social determinants of resilience are very important. One question I had, and this is evident in some of the cancer fields, is whether because the African-American population is so diverse in terms of the geographical origin, whether when you're trying to define a biological determinant, do you think it's important to go beyond clustering all African Americans into one group and look at, for example, West versus Eastern versus North or Sub-Saharan African origins. Again, in some of the breast cancer literature, there clearly are differences in those groups.
Thank you for that question. I could not agree more. And I think it one points to the complexity of the construct and the concept of resilience. And it underscores the fact that, you know, we've been guilty of some of the most imprecise assessments and conclusions when it comes to African Americans imaginable. The African genome is the most diverse genome among humans. You have the widest heterogeneity in the genetic underpinnings of health and health outcomes, enfolded in what we call Black, right? And we have so often used as a single variable, Black, yes or no, being a risk factor. That it really is, I think, a huge and fallacious approach that I think all of us have engaged in, and I include myself in that in the past. So to get into true questions of heterogeneity, I think will be incredibly revealing. We're only at the beginning of that. We stand today with a situation where fully 80% of all of the investigations into the human genome and its implications for health have been carried out in a small corner of the world, or focused on a population emanating from a small corner of the world. That's Northwestern Europe. There's so much more to learn. And if you take that genome, I'm speaking a little bit abstract, if you take that genome and expose it to some horrendous circumstances, you know, the North American experience is one example. You know, 200 plus years of slavery that was brutal and you know, and included not just forced labor, but, you know, tearing families apart, etc. And then that being resolved into this brief period of a reach for equity, interrupted by a long series of really egregious human rights violations, followed by legalized discrimination. You know the story. This transgenerational chronic exposure to adversities of every sort clearly has had its impact. But it also, besides producing people or bad statistics and people who are challenged, it has produced some incredible survivors. And I think there are other stories in the human story collectively that somewhat parallel this, but in modern times, there is no population in which there has been such a natural experiment, if you will, that throws into relief the notion of human resilience. So when you have successes under those circumstances, I think we're compelled to try to understand those. The psychological underpinnings of success in that environment, and the biological ones for you know, health and longevity under such circumstances. So all of that to say, and I don't know why I'm so long-winded today, but all of that to say, I agree entirely with your point. We need to know more about you know, the specifics of continental origins and ancestry and some of the outcomes that we confront on a day-to-day basis. And I think all of that will be to the good, because the more we understand about the broader family of man, the more we'll be able to be more precise, a catchword these days, in our approaches, whether they be in the realm of cultural competence or in biological competence, let's call it.
Thank you.
Thank you.
Hi, this is Matt Berg. A wonderful presentation. You know, I'd like to return to Eric's question about resilience training. You know, in the factors that you've identified, they clearly speak to aspects of the lived environment, the safety of the neighborhood, social
Yes.
cohesion, things of that kind. My concern is that if we just go to those red neighborhoods and do resilience training, we're essentially saying, you know, look, you live in this red neighborhood, it's your personal characteristics that create this.
Mhm.
It's sort of like blaming the victim.
Right.
Um, at the same time, the question then becomes, how do we transform these neighborhoods, or how is it that the blue neighborhoods became blue neighborhoods and the red neighborhoods became red neighborhoods?
Mhm.
And how do we identify those factors that then are potentially actionable? Could, could you share your thoughts about how
Yeah.
one might go about accomplishing that?
Yeah. I think okay, so, and now speaking of neighborhood interventions, I think it's a huge, I mean, it presents a huge challenge, right? I think, and maybe this is part of the earlier question. You know, why would you restrict the intervention to the areas that are observed to be particularly bad off? Um, should some more universal approach be applied? And what should that approach be? I think that's the next, that's the next stage. What should the intervention look like? And where should it be applied? I think a lot of this that we're seeing so far really points back to observations that have been made for a while now. I think um, perhaps the book Bowling Alone has some relevance here, where it talked about the impact of the decline in social connectedness among people as having real biological consequences. It's interesting to note that the neighborhoods that did better had higher levels of social connectivity and activity with neighbors and social cohesion. Things that we weren't expecting to jump out. We really expected, walkability and food access to lead the way. Those things were important, but they were not, in our analysis, nearly as important as the social aspects. Additionally, the individual psychological characteristics were additive to the positive outcomes, those positive affective states I talked about in terms of low depressive symptoms and so on. So how do you change these things? I think it's a tall order, um, but it's something that we in medicine and sociology and psychology need to to really sort of bend our energies towards vigorously. Some people have suggested at the end of my talks, well, it sounds like, one thing you could do is to have community gardens and have people take part in those things and so on. And I would say to that, yes, I think that might be a part of a comprehensive intervention. It shouldn't stop there. Things that really facilitate social interaction, getting to know your the people who are sharing the environment. Um, uh, I'm looking back at a couple of the questions. So, for instance, um, how often, one of the questions to assess social cohesion was, people in my neighborhood share the same values. One question for activity with neighbors: how often do you get together with your neighbors? These things aren't just, the sort of endorphin related feel good kind of things that are obvious, and I think those things have impact. But also, you know, uh, who do you trust? And so if you know your neighbor, if that's the kind of person that when you leave town, you can ask them to watch your house, or you might even be so trusting as to leave a key with, versus the neighbor being somebody you view with suspicion and you don't like and don't talk to. Those are two very different milieu for you to live in, and one is significantly more stressful than the other. One facilitates not only good feeling, but if you're sick and you need some help, or if you have a question, or you need some advice, whether it's medical or otherwise, but may have eventual medical ramifications, it's there for you. If there are walls all up around you, that clearly not only has social implications, but it can have medical implications. There's a deep literature about social support, about after myocardial infarction, literature about the quality of relationships impacting cardiovascular outcomes. And I think we need to not ignore that and think of that as some soft science, but we have to bring it more into the cardiovascular mainstream in terms of our thinking and our practice. Another long-winded answer to say that I don't have specifics in mind of the intervention, but in league with people who are focused on the behavioral and psychological side of human health, I think we can come up with some pretty good approaches.
Thank you very much.
Well, if there's no further questions, thank you very much for spending an hour plus, Dr. Taylor, and thank you for bearing with the technical difficulties.
Well, thank you. I appreciate it. And I hope that you guys stay safe. Thank you for everything you're doing to help stem this pandemic, and hang in there.
Thanks, Herman.
All righty. Take care now.